Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today, I am going to start a new series of videos on basic principles in surgery. To begin with, in this episode, I am going to talk one of the important topics in general surgery, basic principles, that is shock. So after watching these videos, all of you should be able to understand the definition, types, etiology, pathophysiology, stages, clinical features including symptoms and signs, investigations, treatment, prognosis, and treatment algorithm of the shock. Coming to the definition, what is a shock? Shock is defined, this is a state of cellular and tissue hypoxia due to either reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization, or a combination of all these processes. This mainly commonly occurs when there is a circulatory failure manifested as hypotension resulting in reduced tissue perfusion. Shock is initially reversible, but it must be recognized and treated at the correct time to prevent progression to the irreversible organ dysfunction. So undifferentiated shock means a situation where the shock is recognized but the cause is not known or it is unclear. Then it is called undifferentiated shock. Coming to the various types of the shock, there are basically 4 types of shock: hypovolemic, cardiogenic, obstructive, and distributive. Hypovolemic, cardiogenic, okay. Obstructive, under obstructive, there are 3 types. They are tension pneumothorax, massive pulmonary embolism, or cardiac tamponade. Any one of these 3 can cause obstructive shock. Distributive shock also consists of 3 subtypes. It could be a septic shock, it could be anaphylactic shock, or it could be a neurogenic shock. Coming to the etiology of the shock, I've told you already there are 4 types of shock known as hypovolemic, cardiogenic, obstructive, and distributive shock. So hypovolemic shock, because of it is broadly we can divide it into hemorrhagic hypovolemic shock and non-hemorrhagic hypovolemic shock. Hemorrhagic hypovolemic shock is because of bleeding. It could be external because of trauma or because of non-trauma. Bleeding. If it is non-hemorrhagic shock means fluid loss, it could be because of some reasons like diarrhea, vomiting, or burns. All these things can produce fluid loss. Coming to the obstructive shock, it could be, I told you 3 causes: pulmonary embolism, massive pulmonary embolism, tension pneumothorax, cardiac tamponade, and sometimes even dynamic hyperinflation of the lung can produce obstructive shock. Coming to the distributive shock, it could be because of anaphylaxis, sepsis, neurogenic, sometimes maybe acute adrenal insufficiency. Coming to the cardiogenic shock, this is because of depressed contractility of the heart, or acute valvular dysfunction, or it could be arrhythmia, either bradyarrhythmia or tachyarrhythmia. So that is the various causes of shock. So when coming to the shock, you have to remember one analogy. Imagine a gas station where you will have the gas pump, the hose, the gasoline that is coming, and the vehicles which are filling the gasoline. So imagine this pump station, the gas pump is the heart, the hose is the vasculature, and the gasoline is nothing but the blood. And the vehicles, you have to imagine vehicles are the tissues. Now we can understand it better if you remember this analogy to the various causes for the shock. So the first one is the hypovolemic shock, where the problem is in the blood volume is problem, because there is loss of the blood volume. That is the problem. The various causes are, I told you, it could be hemorrhagic or non-hemorrhagic. So hemorrhage means this may be external hemorrhage, including bleeding anywhere in GIT, or it could be internal, maybe in chest, abdomen, pelvis, retroperitoneum, or even in long bone fractures. There could be a lot of bleeding inside. Or this could be non-hemorrhagic, like vomiting, diarrhea, even diuresis and burns can produce, all these things can produce hypovolemic shock. Coming to the cardiogenic shock, now the problem is in the pumping station, that is the heart. This is problematic now. So the various causes are, it could be myocardial infarction, or myocardial contusion or trauma to the heart, or it could be even some infection, myocarditis, cardiac arrhythmias, that is tachyarrhythmias or bradyarrhythmias, or even inotropic drug overdosage. This could be a beta blocker overdosage or the calcium channel blocker overdosage can cause. Coming to the obstructive shock, now the problem is not in the hose or in the vasculature. Okay, there is some obstruction to the vasculature. So this could be pneumothorax, cardiac tamponade, or massive pulmonary embolism. The circulation is obstructed. So the three causes are tension pneumothorax, cardiac tamponade, and massive pulmonary embolism. Coming to the distributive shock, now the problem is in the vasculature. Here the vasculature is not obstructed, but the peripheral vasculature is dilated too much. So the majority of blood volume is now in the peripheral vasculature and not in the splanchnic vasculature. Normally, in a normal man, normal human being, yeah, it could be man or woman. So the majority of blood will be in the splanchnic blood vessel normally. It won't be in the peripheral vasculature. But in case of shock, there will be abnormal dilatation of the peripheral vasculature, and majority of blood volume will be there in the peripheral vasculature, and that is why it is called distributive shock, because there is some problem in the manner of distribution of this, the blood volume. Normally, it should be in the splanchnic vessel, but because of this maldistribution, majority of the blood volume is going to be in the peripheral vasculature, and that is the cause for the shock. Some of the causes for distributive shock are septic shock, anaphylactic shock, and neurogenic shock. In all these things, there will be abnormal peripheral vasculature dilatation, and the majority of blood, the blood volume will be in the peripheral vasculature. So there will be decreased venous return to the heart, naturally decrease cardiac output, and that will result the shock. Coming to the pathophysiology of the shock, the cause could be any reason. We talked about the four types of shock. It could be anything. There will be low cardiac output except in the distributive shock or the septic shock. In all other three types of shock, there will be low cardiac output. Vasoconstriction occurs as compensation to perfuse the vital organs like brain, heart, kidneys, and liver. Because of vasoconstriction and tachycardia, there is dynamic circulation increases. That means the tachypnea occurs to increase the oxygen saturation. Peripheral veins, constrict, delivering blood from splanchnic system towards essential vital organs. This happens not in the distributive shock. In all other types, there is constriction of peripheral vasculature. Decreased renal blood flow reduces the GFR, and thereby the urine output will be decreased, either oliguria or even anuria. Now, the renin-angiotensin mechanism gets activated, causing further vasoconstriction and aldosterone release that causes salt and water retention. So now the ADH is released, that will produce further concentration of urine occurs. Decrease urine output. When shock persists, the cardiac output falls further. Hypotension and tachycardia occurs, leading to poor perfusion of the coronary vessels. That results in hypoxia. So metabolic acidosis will ensue because the tissue will undergo the anaerobic metabolism. So the metabolites will increase, and the patient will have the metabolic acidosis. Now the release of cardiac depressants produce cardiac pump failure. This is eventually that is what is happening in all shock, except of course the septic shock. So basically it is hypoxia that will result in anaerobic metabolism, resulting in accumulation of lactates, that is the lactic acidosis. Now the cell wall damages, even the sodium and calcium enter the cell, the potassium leaks out of the cell. Okay, now it will cause hyperkalemia, hyponatremia, and hypocalcemia. The intracellular lysosomes break down, releasing powerful enzymes which destroys the own cell. This is what is called sick cell syndrome. So platelets are activated. The platelets also are activated, forming small clots in many areas, resulting in the DIC or disseminated intravascular coagulation. This is what is called consumption coagulopathy, resulting in further bleeding. So this is the what happens in all the shocks except the septic shock. So in summary, in short, what is happening in cellular level? There is increased amount of lactate because of anaerobic metabolism. The sodium and potassium pump failure. Intracellular lysosome is released, and autodigestive enzyme, that in intracellular lysosome will release autodigestive enzyme. There will be cellular death. Increase serum potassium, because potassium will leak out of the cell, it will come out. So there will be hyperkalemia, hypocalcemia, and hyponatremia. Coming to the microvascular level, activation of immune and coagulation system. This happens. Endocrine, the adrenal will secrete cortisol, increased sympathetics and catecholamine. The renal angiotensin axis is stimulated that will result in sodium and water reabsorption and increase ADH secretion. So these are the in summary, this is what is happening at cellular level, in the vascular, microvascular level and the endocrine level. Now let us see the pathophysiology of the individual 4 types of shock. So to begin with, the hypovolemic shock, what is the pathophysiology? The intravascular volume decreases, or there is loss of blood volume that will cause decreased venous return, resulting in decreased ventricular filling that will decrease in turn that decrease the stroke volume will be decreased. Eventually the cardiac output will get decreased. Inadequate, that results in inadequate tissue perfusion. So that is nothing but the shock, hypovolemic shock. The tissues will undergo anaerobic metabolism, releasing lactic acid, that is lactic acidosis, resulting in metabolic acidosis. So because of this shock, hypovolemic shock, the compensatory mechanism will be activated. They are increased sympathetic tone, releasing adrenaline and noradrenaline that will cause increased pulse rate and increased temperature. So coming to the hypovolemic shock, you must know there are 4 classes of this hypovolemic shock, and depending on the various parameters, we have to decide our patient belongs to which class of the shock. Suppose if the blood loss is 0 to 15%, that is class 1. In class 2, it is 15 to 30%. Class 3, 30 to 40% of blood loss. If it is more than 40% of blood loss, then it is class 4. Coming to the parameter of CNS, patient will be slightly anxious in class 1 shock. In class 2, they will be mildly anxious, whereas in class 3, patients are anxious or confused. In class 4, they are confused or even lethargic. Coming to the pulse rate, in class 1, this should be less than 100. If it is more than 100, that is class 2. If it is more than 120, then it is class 3. If it is more than 140, then it is class 4. Coming to the blood pressure, in class 1 and class 2, the blood pressure is normal. Whereas in class 3 and class 4, the blood pressure will get decreased. Coming to the pulse pressure, it is normal in class 1, whereas the pulse pressure is decreased in class 2, class 3, and in class 4 hypovolemic shock. Coming to the respiratory rate, in class 1, the respiratory rate is 14 to 20 per minute, whereas in class 2, it is 20 to 30 per minute. In class 3, it is 30 to 40 per minute, whereas in class 4, it is more than 35 per minute. Coming to the urine output, that is ml per hour. In class 1, it is more than 30 ml per hour. In class 2, it is 20 to 30 ml per hour. In class 3, it is 5 to 15. And in class 4, the urine output is negligible. See, slowly it is getting decreased. And coming to what type of fluid you have to give in these various classes of shock. In class 1 and class 2, it is enough to give only crystalloid. That is more than enough. Whereas, if it is class 3 and class 4 shock, apart from giving crystalloids, we should also give blood to these patients. Coming to the base deficit, it is in class 1, it is 0 to 2 milliequivalents per liter. In class 2, it is 2 to 6 milliequivalent per liter. In class 3, 6 to 10 milliequivalent, and in class 4, it is 10 milliequivalent. See, slowly it is getting increased. Yeah, this is the most important thing you must know about the various classes of this shock and various parameters in this. So, if you are encountering a case of hypovolemic shock, you should be able to, put these patients in one of these classes, either class 1 to class 4, you should be able to put them in one of these classes. So coming to the septic shock, what is the pathophysiology? Here the culprit is some infection, or sometimes it may be injury, but basically it is infection only. Because of the infection, this may release either exotoxin or endotoxin. That infective organism can release this one, and these endotoxin or exotoxin will release inflammatory mediators. Okay, this is systemic inflammatory response will follow, and that will result in diffuse endothelial injury to the vasculature, the peripheral vasodilatation, or increased capillary permeability. So this in turn will result in progressive vasodilatation and maldistribution of blood flow. Instead of more blood in the splanchnic blood vessel, because of the peripheral vasculature dilatation, majority of blood volume will be there in the peripheral vasculature. And this is the maldistribution, and that is why this comes under septic shock. Because of this thing, there will be hypoperfusion of vital organs, resulting in multiple organ dysfunction syndrome, MODS, and eventually multiple organ failure. So coming to the various risk factors for the sepsis, our patient could be having suppressed immune system or immunocompromised patient, extremes of age, either infant or elderly patient, people who received an organ transplant because they are immunocompromised, or patient underwent some surgical procedure or any invading procedures, indwelling devices like Foley catheter, central lines, all these things. Yeah. And some of the chronic sickness like diabetic, alcoholism, renal failure, because these patients are immunocompromised. So this is the mnemonic sepsis. S for suppressed immune system, E for extreme age. So you have to remember this mnemonic for the risk factors for sepsis. Coming to the clinical features, another mnemonic is time. These patients will have high or low temperature, infection, and patient is mentally declined, confused or sleepy, difficult to rouse these patients, and they are critically ill. They are in severe pain and severe discomfort, shortness of breath. So all these things are features of sepsis. These are all the clinical features. For risk factors, you have to remember the mnemonic sepsis, and for the clinical feature, you have to remember the mnemonic time. Coming to the cardiogenic shock, the problem is in the heart itself. So what happened because of the failure of the pump, the heart, the stroke volume is decreased. That results in decreased cardiac output. Naturally, that results in hypotension. So eventually impaired tissue perfusion, resulting in cellular hypoxia, and the tissues will undergo anaerobic metabolism. Okay, because of this decreased stroke volume, that is because of inadequate systolic emptying, that results in increased left ventricular filling pressure or increased preload. This results in increased left atrial pressure, This left atrial pressure in turn will increase the pulmonary artery and the capillary pressure will be increased, that eventually will result in pulmonary edema in cardiogenic shock. So in cardiogenic shock, we have to remember some important terminologies, because now we are talking about preload, stroke volume and all. So what are those terminologies? Okay, let us see. BP is cardiac output and systemic vascular resistance. This is cardiac output into systemic vascular resistance is BP. Cardiac output in turn depends on the heart rate and the stroke volume. What is stroke volume? Stroke volume is the volume of the blood pumped by the heart per contraction. This is decided by preload, myocardial contractility, and afterload. So, what is a preload then? Preload is the ventricular wall tension at the end of diastole. That is preload. What is afterload then? Afterload is the ventricular wall tension, the same ventricular wall tension, but at the end of systole. This is the difference between preload and afterload. Coming to the neurogenic shock, there is disruption of sympathetic nervous system. Okay, this results in loss of sympathetic tone over the venous and arterial. This results in venous and arterial vasodilatation. Because of this, there will be decreased venous return. Because of the decreased venous return, there is decreased stroke volume, eventually resulting in decreased cardiac output that will finally result in impaired tissue perfusion and cellular metabolism. The neurogenic shock, the classical example is the spinal cord injury. Yeah, that is the example for neurogenic shock. Coming to the various stages of shock. Stage of hypoperfusion and hypoxia. Aerobic metabolism changes to anaerobic metabolism, leading to lactic acidosis, resulting in the metabolic acidosis. The next stage is stage of compensatory shock. It is neuroendocrine response to maintain the perfusion of vital organs like brain, lungs, and heart. Noradrenaline, renin-angiotensin, and antidiuretic hormone ADH gets activated, causing vasoconstriction of organs like gastrointestinal, kidney, to divert the blood to heart, lungs, and brain. This is compensatory shock. While the BP will be compensated to some extent. The next stage is stage of decompensatory or progressive shock. Here, the compensatory mechanism fails. Cell perfusion decreases, causing raised intracellular sodium but low intracellular potassium. Microcirculation fails, beginning the failure of kidneys, liver, and even lungs. The next stage is stage of irreversible or refractory shock. Here, the cellular ATP metabolism is lost completely. It is lost completely, leading into multiple organ dysfunction syndrome and eventually multiple organ failure. So coming to the clinical features. So what are the symptoms in shock? I am not discussing about any one particular type of shock. Any shock, you have to assess the severity of the shock depending on whether your patient is having dyspnea, whether confused, whether patient is having lightheadedness, drowsiness, oliguria and anuria. All these things will show the severity of the shock. Of course, we have to look for the symptoms of the cause. Suppose if it is cardiogenic shock, naturally patient may have chest pain. If it is septic shock, there will be symptoms because of sepsis. So like that, you have to look for the symptoms of the various causes for the shock. maybe trauma in hypovolemic shock. So coming to the what are the various signs you have to look for in shock, any type of shock. The first thing is your ABCD only, airway. Airway may be compromised by because your patient has got reduced consciousness level. Breathing hypoxia may result secondary to airway compromise. Some of them may go for Kussmaul's breathing because hyperventilation to compensate for metabolic acidosis. This is a compensatory mechanism. Patient may go for Kussmaul's breathing. Circulation, there will be cold and clammy or cold and pale extremities will be there. There will be prolonged capillary refill time. CRT is more than 2 seconds. Patient have tachycardia, oliguria or even anuria. Coming to the disability part, patient is confused. This is the neurological, either confused, drowsy or totally unconscious. So coming to the, what are the investigations you have to do in case of shock patient? You have to draw blood for blood gas to check for pH and the lactate level in the blood. You should also do a ECG and chest X-ray to rule out any cardiogenic problem. You should measure the CBP, pulmonary capillary wedge pressure, cardiac output, systemic vascular resistance. All these things you have to record. You must do an echocardiogram. In trauma patients, you can do a pelvic X-ray, CT scan of thorax, abdomen and pelvis, and E-fast scan, especially if it is a blunt injury of the abdomen. Okay, there are some physiological characteristics for various types of these shocks. If it is hypovolemic shock, you have to record this CVP and pulmonary capillary wedge pressure, cardiac output, and systemic vascular resistance. And another most important thing is venous oxygen saturation. That also you have to record. This is what is called mixed venous oxygen saturation. The normal is 50 to 70%. Usually this is less than 50 if there is inadequate oxygen delivery, especially with hypovolemic or cardiogenic shock. You will be having less than 50% of mixed venous oxygen saturation. If the mixed venous oxygen saturation is more than 70%, this happens in sepsis and some other forms of only in distributive shock. We will have this increased mixed venous oxygen saturation. In all other types of shocks, there will be decreased venous oxygen saturation. All these parameters you can just pause the video and you can see. See, in hypovolemic shock, the CVP and pulmonary capillary wedge pressure will be decreased. Naturally, the cardiac output, the systemic, both are decreased, but the systemic vascular resistance will be increased. The venous oxygen saturation is, I told you already, this will be less than 50%. So that also decrease. In cardiogenic shock, what are the parameters? You can just pause the video and just go through this one, so that if you measure all these things, you can exactly pinpoint what sort of shock we are dealing with. But in the surgical side, we are dealing with mainly hypovolemic shock and septic shock. So all other shock, cardiogenic shock, will go to cardiologists. The neurogenic and hypoadrenal, all these shocks will be dealt with by the internal medicine physician and usually not by the surgeons. Surgeons should know very well how to manage a hypovolemic shock and a septic shock. Septic shock, again, two types. It could be initially hyperdynamic or warm shock, or it could be hypodynamic or cold shock. Please note these variables, I mean the parameters, variable parameters, so that exactly we can pinpoint what type of shock we are dealing with. So please, this tabular column is very important. Please go through it after pausing the video for some time. So now it is the initial management of the shock. We have to assess the patient from an ABCDE perspective. Maintain a pattern airway. We can use maneuvers, adjuncts, and supraglottic or definitive airways as indicated, and suction. We can do suction for any sputum or secretion. Deliver high flow oxygen, that is 15 ml per minute via reservoir mask to keep the saturation over 94%. Attached monitoring, you have to monitor pulse oximetry and non-invasive blood pressure monitoring. Start doing initially the 3-lead cardiac monitoring and request for the 12-lead ECG monitor and portable chest X-ray. Obtain large bore intravenous access and take bloods including blood gas to check pH and lactate. Fluid resuscitation should be given through the peripheral IV lines. Urethral catheterization and fluid balance monitoring should be, you have to do aiming for the urine output of more than 0.5 ml per kg per hour. If BP fails to respond, consider referring the patient either to high dependent unit or ICU for central line incision with central venous pressure monitoring and central venous oxygen saturation monitoring. Arterial line incision and invasive arterial BP monitoring, and you can also start vasopressor and inotrope infusion. So all these things better do it in either in high dependent unit or ICU unit. Coming to the further management of the shock, we have to identify what sort of the shock we are dealing with, and we have to treat the cause of the shock. If it is a hemorrhagic shock, you have to identify the source or the sources of the bleeding and achieve hemorrhage control by either the direct compression, pelvic binder, splintage of the long bone fractures, surgical ligation of the bleeding vessel. Restoration of adequate circulating blood volume is a must. And cross-match blood and activate the major hemorrhage protocol. Transfuse O negative blood initially, O negative RBC, followed by type specific and fully cross-matched blood as soon as it is available. Aim for permissive hypotension is possible for some time. We have to correct coagulopathy by transfusing platelets, FFP, cryoprecipitate as appropriate. The RBC and FFP transfusion ratio should be either 1:1 or at least 1:2. The optimum ratio is uncertain. The key is to give FFP early along with the RBC infusion. Cryoprecipitate should be given if fibrinogen level is less than 1.5. We have to give antibiotics and source control in case of septic shock. We have to do that. We have to give adrenaline 0.5 milligram intramuscular for anaphylactic shock. Needle thoracocentesis and intercostal chest drain should be inserted in case of tension pneumothorax. Pedicardiocentesis and thoracotomy for cardiac tamponade. Thrombolysis is for massive pulmonary embolism. Synchronized direct current, that is DC cardioversion, for case of unstable tachyarrhythmias. If it is bradyarrhythmias, then you can go for pacing, artificial pacing. You can do it. Coming to the prognosis in various types of shock, this is called shock index is the main thing you must know to tell the prognosis of the shocked patient. That is, shock index is nothing but heart rate divided by the systolic BP. Yeah, normally this should be less than 0.6. If it is less than 0.6, that means your patient is not in shock. Suppose the mortality, even then, the mortality is 10.9% mortality. Yeah, patient is not in shock, but patient is having some problem, and that is why this mortality. If it is mild shock, this shock index will go up to 0.6 to less than 1. That is mild shock. Moderate shock means it is more than 1 up to 1.4. Severe shock means the shock index is more than 1.4. Now the mortality is almost 40%, 39.8, that is around 40% mortality if it is a severe shock. So this shock index is very important to know the prognosis in case of these shocked patients. Coming to the algorithm for shock treatment. So the first thing is, this is A, B, C, D, E, okay. But the first thing is you have to do a focused clinical history and examination of the patient with shock. This is nothing but your history and physical. Then immediately you have to stabilize the patient, secure the airway if necessary, establish the IVSS, administer initial intravenous fluid bolus while considering the etiology of the shock. You have to draw the blood for laboratory studies. So then now, after doing all these things, now we will be knowing the 4 types of shock. If it is distributive shock, if it is anaphylactic one, give epinephrine. If it is because of adrenal crisis, we have to give IV dexamethasone. If it is a neurogenic shock, we have to give volume resuscitation, then we have to give phenylephrine. If it is because of sepsis, then give IV antibiotic, volume resuscitation, vasopressor, and source control. That means you have to control the source of infection. That is what you have to do. If it is a gangrene, diabetic gangrene, you have to do an amputation. If it is an abscess, okay, that is the source of infection, then you have to drain that abscess. If it is hypovolemic shock, that is the hemorrhagic shock, volume resuscitation, you have to control the bleeding by direct pressure, and even emergency surgery you can do to control the bleeding. If it is obstructive shock, if it is cardiac tamponade, do pericardiocentesis or pericardial window and do volume resuscitation also. Pulmonary embolism means go for thrombolysis. If it is tension pneumothorax, go for needle thoracocentesis, or you can put a chest tube incision. If it is cardiogenic shock, myocardial infarction, you have to give inotrope drugs, coronary revascularization, or even intra-aortic balloon pump can be used. If it is a ruptured valve, surgical valve repair should be done. If it is arrhythmias, we have to follow the ACLS protocols. Now, this is another treatment algorithm. The same thing they have given here elaborately. I request my viewers to pause the video and please read all these things. This is only a repetition. The same thing they are discussing, the 4 types of shock and how to manage. Please pause the video and go through these details. So thank you very much for watching this video. If you think that these videos are very useful to you, kindly subscribe to this channel and share these videos in your social media. Kindly click the bell button also to get notified regarding my latest uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye-bye.